Good afternoon, and it's my pleasure to welcome you here to EBMT in Valencia, Spain, and it's my special privilege to introduce you to Professor Prof Mohty, who is not only the president of EBMT, but the host of this year's Congress, and we're here to discuss some of the highlights of the meeting. So Mohammed, perhaps you can share with me what has particularly struck you during this meeting in the space that you and I work in, which is obviously on the one hand transplant and on the other multiple myeloma.
Yeah, well, thank you very much, Paul. It's really a pleasure being here. And as you have noticed, this is definitely a very exciting meeting. It's an amazing meeting because of all the novel issues that has been discussed. Myeloma has been like almost a superstar during this meeting. And this debate about auto versus no auto transplant in myeloma. But we had also many sessions about the novel drugs. And as you know, we had the opening lecture, which is like the most prestigious lecture of the meeting, by Jesus San Miguel, who made I would say, the past, present, and future history in myeloma.
I agree. I thought Jesus' presentation was quite superb. And I think speaking to that, I think what we were so privileged to have this afternoon with Professor Jean-Luc Carousseau and your and my discussion was a framing that autologous transplant remains clearly an important option for younger patients who are eligible. But I think as we look to the future, I think there was a consensus that whilst it is an option, one size does not necessarily fit all. And there may be patients in whom it can either be delayed, or in fact, there may even be patients we can identify in the future who might be spared some of the side effects of the procedure with the goal of achieving the same thing using some of the newer tools that we have, both in the context of assessing minimal disease and at the same time, some of the most exciting new drugs. And I think monoclonal antibodies were a real feature of this afternoon's debate. What's your take on what you've heard about both daratumumab, for example, and then some of the other monoclonal antibodies, such as elotuzumab, that have been recently approved?
No, I think you're right. The debate and the case for auto transplant in myeloma is not closed. And I think both Jean-Luc Carousseau and yourself made very good points regarding whether we should proceed or not. And I think, as usual, it's never black and white. Right. The truth is always in between. Yes. Obviously, I think here we are in a European perspective, and people are very convinced by the role of auto for several reasons: historical reasons, drug access reasons, of course, feasibility, safety, etc. There is a long history of auto myeloma. And I think the recent IFM 2009 DFCI joint trial is in favor of auto transplant, at least when you look to progression-free survival. We do agree that there is no advantage in overall survival, so it's legitimate to ask the question, is it really mandatory to everybody? Especially that we can maybe salvage them or we can delay transplant. So it's rather for me a philosophy in your treatment than I have 100% argument in favor of this or that.
I agree, and I think the important message from this afternoon to me was that in the context of countries, access to new drugs really matters, because in point of fact, that can determine your choices. For example, in a country which may not have access to optimal salvage regimens, an auto-transplant early may be the best strategy for that particular patient in that particular health system. Obviously in the US, we're blessed with access to new drugs and a very different and more dynamic and more varied array of therapeutic options, which changes the way we view this. I think another critical point, speaking to the data, is that, as you point out, there is no survival difference yet. With time that may emerge, but the progression-free survival benefit of transplant over no transplant early versus late was 8.8 months. And I'm very struck that lenalidomide maintenance as part of continuous therapy confers 2.5 years of progression-free survival benefit, not just in one, but several trials, and has been further validated by Dr. Palumbo's work. So I think in aggregate, we're left with really open questions. And I thought today's debate was very refreshing, because I think Jean-Luc and I agreed on pretty much everything. And I think what was really nice, though, is that we both brought out
at the end there was an agreement.
Oh, absolutely.
There was an agreement.
And the US trial, I think also for us, shows a way to the future, because it shows that in America, by us partnering and running a parallel study to our French colleagues, were able to ask actually importantly different questions, but at the same time have a very similar and identical parallel track which will allow us to answer key aspects of the same question.
I think, Paul, you're raising here an important question, which is the length and duration of maintenance.
Yes.
Because definitely these results should be always read and interpreted in the context of the design.
Right.
So if you have a relatively short period of maintenance, it may be a totally different story than giving until progression. And that might explain these differences. So we have to acknowledge this. I would like to go back a little bit to the issue of access to drugs. I think this is also a very important point. However, it's important for our community to acknowledge that this issue of access is extremely important. And I think we should put all our energy and forces all together, all stakeholders, to make all of the novel agents available to all patients all over the planet. Yes. I think this is our ethical responsibility. But we should be careful that this argument of access should not be an obstacle to the progress. I think it's a dynamic field. Everything is in movement there. Therefore, while trying to sort out these problems, and they may be different from one place to another, even in Europe, not everybody in Europe is within the same laws, same rules, etc. I think we as a myeloma community, we should really focus on how to design the best treatment that will ensure the longest overall survival with the lowest toxicity. And this is very important to keep in mind.
I agree. And I think that, again, we have to be also very realistic about differences in choices that patients face in different continents, in different countries, in different healthcare systems. But the fundamental premise of better access to all these exciting new advances is absolutely fundamental in my view. And I think that's something that we as a research community are wholly committed to, as you know, from our international efforts and our strong collaborations. Changing gears a little, Mohammed, obviously you and I have been working very closely together on the development of defibrotide, talking of improving outcomes and reversing devastating toxicities. And I think it's been particularly momentous for us together as friends and co-investigators to be here on this particular EBMT, where we've had quite a series of landmark events. Perhaps you can outline for me what you think of the recent approval, the various papers. You've been a lead author on a key one. Perhaps you can comment.
No, I mean, here you're raising another one important feature of this meeting. I think this is a fascinating story, really fascinating story. It was a true adventure. And it's a pleasure to see that after 20 years of huge, important development, this drug is now available and approved both in Europe and in the US. I think all of us in the community are very pleased. This is an orphan complication. It will be very, very difficult to gather thousands and thousands of cases. And actually, we don't want to have thousands of cases of VOD, by the way, because mortality is terrible. More than 80% mortality in case of severe VOD. So I think now we have in hand a drug that can work.
Yes.
And it is our responsibility to try to refine what is the optimal way to use defibrotide for VOD. And I think the story is just starting, because when it comes to VOD, or SOS as you prefer, we're talking about endothelial cell dysfunction.
Exactly.
And the endothelial cell dysfunction, this is a wide spectrum of very rare complications. We are very familiar in the transplant field, where we are a little bit lost sometimes. Of course, we always use steroids. When we don't know, we use steroids. But this is now rejuvenating the field, and this is huge. And one of the efforts we did, and you are a key player in this project, the revised EBMT criteria for diagnosis and prognosis and grading of severity. These criteria will be published hopefully soon, and they will represent a turning point, because the idea in this complication, because of its very bad prognosis, to be able to intervene very early.
Great.
If we want to save lives, we need to intervene very early. And if you want to intervene very early, you need to have a very close monitoring and assessment and to be able objectively to evaluate the situation. And I think we're doing some good job. We owe this to our patient, and I hope we will succeed.
Well, I agree, and I think the journey with defibrotide has been one that's been long but thoroughly worthwhile because, as you so correctly point out, whilst the various syndromes that we've targeted, particularly VOD-SOS with DF, are relatively uncommon, I think the endothelial platform is huge, and that underpins so many other issues that can be so challenging for our patients. So one can envisage where defibrotide becomes a backbone agent that then provides us with both a preventative strategy in the future as well as something that can be used in combination with other new agents or even established agents such as solumedrol to reverse syndromes that hitherto have sort of defied our therapeutic efforts.
And GVHD.
Well, exactly.
Let's not forget GVHD, acute GVHD.
Well, that's almost exactly where I was going.
In the prevention trial,
exactly, from the EBMT.
Published in the Lancet in 2012, there was a clear indication that defibrotide may reduce the incidence of acute GVHD. It needs to be validated,
yes, right.
But I think this is a good start.
Well, it's an extraordinarily important start because, again, I think no one's arguing on its own, but the point is that it becomes part of a combinatorial approach to reversing a variety of endothelial-based toxicities of various stripes. And I think in that note, the expansion of the therapeutic index has been very exciting to see. We've got the therapeutic opportunity of prevention coming. But what was particularly exciting to me at this meeting was to see the enormous impact that defibrotide is having in children. The pediatric piece was remarkable, and I thought at the session that you and I were part of, and it was a privilege to be part of with you, Mohammed, I was particularly struck by the contributions of our pediatric colleagues, Jean-Hugh and, of course, Selim Korbaçoglu. Very, very informative and very gratifying to see.
No, definitely. I think here it's very emotional when you listen to their talks about these very rare inherited syndromes.
Yes.
And
it's
these
very real for the patients and families.
Absolutely. Yeah. Terrible situations.
Yes.
These are very high risk factors for VOD. And being able to administer the necessary drug, I would say, for these patients, I think everybody would be happy.
Well, to me, the sort of one of the key moments of the whole meeting was that description from Jean-Hugh of the poor child who succumbed,
3 months baby,
succumbed, the infant who succumbed from without treatment, and then the juxtaposition from Selim of a very similar, very ill child, complete reversal, complete resolution, and walking out of the hospital. It was, I mean, for me, this was just very, very striking.
No, definitely. I think we agree. As part of this meeting, we have the nice defibrotide story. We mentioned all the novel drugs in myeloma. We had also wonderful talks, for example, in CLL, chronic lymphocytic leukemia. We had ibrutinib, and this is not our favorite topic, but I'm very excited. We're going to a chemo-free era.
Yes, so biologically targeted therapies.
Absolutely
across
amazing.
All these diseases.
Lots of sessions about cellular therapies.
Yes, I think a wave of the future, and also in myeloma this will
absolutely.
be real.
We just had a session about fecal transplantation. Who can believe this? That fecal transplantation, whether autologous or allogenic, can improve the outcome of GVHD, at least potentially. We still need to do the trials, but there are strong indications that you can improve the outcome of stem cell transplant. We're using fecal transplantation. It's absolutely, we are now exploring new frontiers.
That's a real new one.
Absolutely, absolutely.
So, but you know, that's very interesting because that does very much resonate with the microbiome story and the remarkable story from the German groups about the importance of antibiotic prophylaxis and what you use and when you use it. And by changing the gut flora, you can dramatically improve outcome.
The key question is, with our antibiotics, with the chemotherapy we use, actually we are deregulating. We are creating a state of dysbiosis.
Quite.
And the key question is now, how are we going to restore a normal microbiome?
Fascinating.
And one way of doing it is this fecal microbiotherapy or transplantation. But I think the bottom message here is that it's a fascinating area. I mean, if you look at all of these new frontiers that we are tackling.
So as we look to this new era in myeloma therapy, where we've got such exciting new treatments, there's a very real concern about late toxic effects. And I think that we're learning a lot more about those. I think the good news is that secondary leukemias do have a salvage rate, but if we can possibly avoid them, so much the better. And I wonder, Mohammed, because at this meeting I'm struck that there is a concern that as our patients live 10, 15, 20 years, we really have to think about where we place our therapy and what we use, because obviously we beat myeloma, make it a chronic illness for 15, 20 years, but then our patient in the middle of that process develops secondary leukemia from prior exposure to melphalan. That is something we need to work to avoid. Thoughts on that, particularly in the context of today's discussions?
Yeah, I think this is really more and more important. It's even crucial. It's not only about survival. We need to introduce and really consolidate the concept of complications-free survival. It's really important. We need life quantity, but we also need quality. So we don't want these late complications, late side effects. And second primary malignancies are one example, because if you have an elderly patient, 70 years old, which can live for another 10 years, you may encounter these complications. Having said this, we should not forget from the other side that when it comes to myeloma, for example, all patients, unfortunately, first cause of death, we know it's myeloma. So we really need to find a sort of a balance while analyzing carefully, monitoring the trials, looking carefully to the side effect, to the adverse events, calculating the incidence, etc., etc. We should be careful not to amplify or to create a situation of fear and avoid giving a good treatment to a patient. Right. So it's important to be aware, to assess the situation, but also to know that the disease by itself is probably the most important cause of death.
And I think for the first time, we're now in a situation in myeloma, for example, where we can pick and choose. Yeah. And I think that's an incredible thing that we can offer our patients, is that, again, driving back to what we were talking about before, if we believe that one size does not fit all, there may be distinct genomic, physiognomic patterns that we can identify in certain patients to spare them toxicities that perhaps other patients can tolerate and get benefit from. But for those who may be particularly vulnerable, we can actually look to alternative strategies to get them to the same place, but not then have to face the late consequences of say, a genotoxic treatment.
Actually, we still have a lot to do.
Yes,
and this is all, with all the available agents, this is now where the sequencing job will start.
Exactly, and sparing and efficacy considerations accordingly. So as we think in the new spectrum of drugs in myeloma, obviously we've already touched upon the excitement around the monoclonal antibodies. We've got the ongoing excitement around the next generation IMiDs, particularly with the success of pomalidomide. And now, of course, we have next generation proteasome inhibitors. And we have, on the one hand, carfilzomib, which has shown such remarkable activity with tremendous improvements in progression-free survival compared to be it lenalidomide-based therapy or bortezomib-based therapy. And of course, now we have the oral ixazomib, which in itself, a weekly pill combined with an IMiD, improving PFS with excellent tolerability. Thoughts, Mohammed?
No, cannot more agree. Actually, during this meeting, we had only good news because we heard about the positive CHMP opinion regarding daratumumab in Europe, which is really good news for us after the US approval. First monoclonal antibody targeting anti-CD38. This is really a breakthrough achievement.
I agree.
We had also several talks indeed and several discussions about these second generation proteasome inhibitors. Because as we all know, we lived like almost 15 years with the first generation, bortezomib. And now we have in hand second generation, which are more potent and with a better safety profile. And I think this is now changing the landscape. Carfilzomib, the data is quite appealing. Of course, it's IV, so you may think an oral is better. But I think there's room for all of these agents, and we need to refine who are the best candidate. But I think the KRD, carfilzomib, lenalidomide, dexamethasone data published in the New England Journal, which were discussed a lot during this meeting, about the triplet use of salvage therapy in relapsed refractory myeloma is very exciting. IRD, ixazomib, lenalidomide, dexamethasone. I mean, being able to deliver a triplet oral combination, ixazomib once per week, excellent safety profile. This is a huge progress for our patients.
I agree, and I think that one also mustn't forget that this is not a zero-sum game. It's not one versus the other, that we have the advantages of bortezomib, its relatively powerful effects in renal disease and so forth. Obviously, neuropathy is a nuisance, but it's otherwise generally well tolerated. And given that the neuropathic signal can be so challenging, it's great to have something like carfilzomib, which is so non-neurotoxic. But again, we have to be a little careful. There is this vascular signal from carfilzomib that we must be careful about. The flip of that is that ixazomib appears to have less neuropathy than bortezomib, doesn't have the vascular signal that some of the other more potent proteasome inhibitors may have. So we now have choices. And I think for our patients, that's wonderful because we can not only pick drugs on the basis of efficacy, but also how they might best partner with a particular patient because of a side effect profile that may be favorable to that particular patient.
Well, actually, this is where you can guess the passion of medicine, because this is where clinical judgment,
absolutely,
on a case-per-case, patient-tailored treatments, and actually you want to have all options available,
yes,
and then the clinical judgment will allow you to design. First of all, you need the clinical trials. Of course, the procedure is there, but once you've got the approval, then the real-life effect will be seen. I think we are.
I think that's
happy.
A perfect note to end on, to say that on the one hand, we have extremely elegant bench-to-bedside science with small molecules, monoclonal antibodies, and genotypic data, really at the highest quality and the greatest technology. But we must never forget some of the most basic lessons that are staring us in the face.
Absolutely.
And I think on that note, Mohammed, it's my pleasure to say thank you very much for being with us today.